A very good morning to everyone, and thank you very much, Sudip sir and Shona ma'am, for this opportunity. So I'll be discussing three abstracts quite quickly. The first looks into the long-term quality of the life in patients with breast cancer after the breast conservation surgery vis-a-vis the mastectomy with reconstruction. This was presented by Summer Hansen and was published in JAMA in 2022. So the background being that the RCTs have shown similar relative risk and survival in BCT with RT versus mastectomy with or without reconstruction, but there have been no studies on the quality of life of each category. And there have been increasing concerns about the increased rate of the mastectomy with reconstruction in the US, hence the need to look into this. And there were certain questions that needed to be answered in measuring the quality of life of these patients, the physical well-being as well as the psychosocial well-being. It was a retrospective analysis of the data that was published in Texas-based registry, and the study population included the stage 0 to 2 females with breast cancers treated between 2006 and 8 with BCT with RT or mastectomy with recon, and the follow-up was till 2016. Majority of the cohort though was T1 intermediate or high-grade tumors, but node negative and hormone positive. So the primary outcome was satisfaction with the breast, and it was measured by breast Q, patient-reported outcome measure, and the secondary outcomes were the breast Q, physical well-being, psychosocial well-being, and the sexual well-being in these patients, and the health utility measured by the European quality of the life, health-related quality of life, which looked into 5 dimensions and was a 3-level questionnaire, and also local therapy decision target regrets were looked into. We had 647 responders, 357 had undergone BCT with RT, 291 mastectomy with recon. Median age was 53, although the range was 23 to 85, and the median time from the diagnosis to survey was 10.3 years. So there was multivariate analysis, and it showed that no significant difference between BCT with RT versus mastectomy with recon in satisfaction with the breast. But when it came to the psychosocial well-being and sexual well-being, the mastectomy group fared worse, significantly worse. Health utility and the decision regrets did not differ in either. So the authors concluded that the BCT with RT is equivalent to mastectomy with recon without RT for early breast cancers in terms of the breast satisfaction and physical well-being. However, it fares better in terms of the psychosocial and sexual well-being, and hence these findings will help inform preference-sensitive decision-making for women with early breast cancer. So there was an invited commentary by Sudhir et al. On the same that pointed out that the earlier studies that had been done were quite heterogeneous, and there were a lot of potential co-founders because there was no head-on comparison, and this was the first where the head-on comparison of the BCT with RT versus mastectomy and reconstruction without RT was being done. And another important finding is significant disparity in patient-reported outcomes associated with social detriment of the health. American Indian and Alaska Native patients had worse quality of the life across all measures, whereas those identified as Asian American, Pacific Islanders, and Hispanics had lower patient-reported outcome. So furthermore, Hansen et al. Found that higher income and higher levels of the education were independently associated with better patient-reported outcomes. So interesting fact is that race and ethnicity and income did have some influence on the decision making, but the level of education did not impact it. Hence, our patients might be educated and yet ignorant of the available choices or the impact of those choices on the oncological safety as well as their quality of the life. Or there might be some inherent socio-cultural biases that need to be addressed while making decisions with them. And unfortunately, in our part of the globe, a lot of decisions are not being made by the patients themselves, but by the males who accompany them. So globally, the concept of BCS had started in 1970s, but we were a little slow because of various reasons. And now that the quality of the life issues are coming up and they're adding a new dimension, we should offer the patients all the information related to their decision making, and a lot of patients opt for mastectomy because of the fear that it will not be removed, the tumor will not be removed completely, or because they are not given the option, or because the primary consultants don't know how to offer the oncoplastic surgeries, and they're being forced into mastectomy. So the take-home message is that with increasing quality of the mammograms and the radiation machines, it is our prime responsibility as treating surgeons to discuss the feasibility of the BCT and RT in all the early breast cancers, and we have to look into bridging the gap no matter what we do. If it is not accessible and available to the masses, then we are not where we should be, and all those disparities have to be looked into. And breast QA is something that was designed for international patients, and if we want to do it on our patients, we have to have a questionnaire which is validated on our own patients, and it has to be feasible, it has to be understandable by our own patients. Abstract second is the prospective surveillance of the breast cancer-related arm lymphedema. So it was a systemic review by meta-analysis by Boll-Raffin and was published in Journal of Clinical Oncology. The objectives were the women who underwent ALND basically as a part of their breast cancer surgery had a higher risk of the lymphedema, 1 in every 6. And early lymphedema or subclinical lymphedema is reversible. And once it becomes chronic or intradermal fibrosis sets in, it's very difficult and it becomes a huge financial burden for the healthcare system as well as for the patient. So there's a potential window of the intervention which we have to identify and have to do measures to reduce that or reverse that. This systemic review by meta-analysis is the first to examine whether such programs or the active surveillance programs basically reduce the risk or not. The RCT's observational studies from 5 databases and 2 registries were included, and the studies involved participants who had received any type of the surgery, and then those who were not in the breast cancer surgery group were excluded. So the interventions were looked into, and the prospective surveillance programs were actually evaluated to identify the lymphedema that involved a minimum of 3 planned post-surgery assessments and early management if the lymphedema had been identified. So the studies that reported on incidence, prevalence, and severity of the lymphedema all were included. That had been published until February 2021. And data on early lymphedema management, whether it was resolved or not, and who progressed into chronic lymphedema was also looked into. There was no restriction on the data and language. Pooled relative risk and pooled rate cumulative incidence observational studies of the chronic lymphedema was calculated, and the selection of the studies was performed independently by 2 reviewers. Any inconsistencies were looked into by the 3rd reviewer. So all models prior to this were not feasible and cost effective. Hence, this analysis was done to answer the following questions: which patients should be assessed, which assessment methods have to be there, what should be the frequency of those assessments, and the length of the follow-up that is needed. So results showed that planned subgroup analysis, when it was performed, it looked into retrospective and prospective cohorts, the patients with ALND, and length of the follow-up. There was a lot of heterogeneity basically. So there was a huge heterogeneity in the age group, the heterogeneity in the time of the assessments, the frequency of the assessments in these patients, the pressures that were used, the methods that were used, various diagnostic criteria that were used. But the 19 out of 93 articles that were screened, finally only 21 studies could be included because of the availability of all the data that was required. And the pooled rate of the chronic lymphedema was 4% overall, but when we looked into the group that had ALND, it was 6% in those who were a part of those surveillance programs. Otherwise, it is 20%. So the prospective surveillance programs should involve at least 3 assessments and should look at the delivery of the treatment when it is identified. So there were additional sub-analysis of the whole thing. The first cumulative incidence of the chronic lymphedema among women with ALND who had participated in was 6%, and it is especially relevant for the subgroup of the patients at the higher risk of the developing chronic lymphedema. That is what we are reiterating. And the second cumulative incidence of the chronic lymphedema increased over the time until 24 months. So we have to continue these surveillance programs at least up to 24 months, and there have to be at least 3 assessments. So again, another interesting fact is that the recent data suggests that these chronic lymphedema particularly affect the survivors of the low socioeconomic status, potentially because it stays underutilized over there, or they're not given that option because of various reasons, because of the cultural biases, ethnicity biases, or because of the insurance issues. So the prospective surveillance programs can potentially contribute to this inequity if they come with the cost, or if they focus on the treatments or interventions in which the patients have to be coming to that facility time and again. As we already discussed, the limitations were the huge heterogeneity in measurement methods, diagnostic criteria, interventions, pressures, etc. And there is, so the take-home message in this is prospective surveillance programs with early management and the risk of, reduce the risk of the chronic lymphedema. Maximum benefit is seen in the high-risk patients, and there is a need for standardization of the definition of the chronic lymphedema and standardization of the methods and the criteria, and outreach programs have to be offered to the patients who cannot come to the facilities. The abstract third was from our TMH and the Sydney, and it was submitted by Vincent Paramanandanam. Prophylactic, it was about the prophylactic use of the compression sleeves that reduce, whether it reduces the incidence of the arm swelling in women at high risk of breast cancer-related lymphedema. With a randomized controlled trial, a lot of the heterogeneity in the previous one was being taken care of in this, and the author's conclusion was that it's the first RCT with concealed allocation and adequate power to evaluate the prophylactic use of the compression sleeves in prevention of the chronic lymphedema in high-risk groups. And for women at high-risk group, prophylactic use of the compression sleeves in addition to the usual care did reduce and delay the incidence of the arm swellings. So such programs need to be started. And the take-home message again, there was a lot of overlap in the previous and this, but the only thing being that a lot of heterogeneity was taken care of in this controlled trial. But the questions that need to be addressed is that we don't know exactly who will be the patients who will develop the chronic lymphedema, because a lot of the patients who present in the first year basically do get reversed. So are we basically over-diagnosing and over-treating if we are treating them in the first year is something that needs to be addressed. And so I think that's all. Thank you.